So, as we continue our study of respiratory physiology, there are two key pieces we need to go over. We talked about pulmonary ventilation, which is breathing, moving air in and out of the lungs. We discussed how those volume and pressure changes are going to allow that to occur. We now need to focus on external respiration, which remember is gas exchange between your blood and the pulmonary capillaries and your lungs. And then in the next lecture, we'll focus on internal respiration, and that's the gas exchange between your systemic capillaries and your tissues. And so as we explore these topics, we'll look at factors that affect it and also how the gases are transported. But first, we need to cover two gas laws. If you look at room air, if I were to run around my room with a jar and collect a sample of air and look at what's inside, notice that we're surrounded mostly by nitrogen, N2 is how it's written. So roughly 79% of the air around us is nitrogen, and it's in our inhaled air. We breathe it in. It's just not very soluble, so we breathe it out. It doesn't go into our blood normally. O2 is around 21% is what we say of room air. We have a little bit of water vapor, that depends on the humidity, and then room air is very, very low in CO2, only 0.04%. So we need to look at something called partial pressures. And partial pressures, basically just what it sounds like, it's the pressure exerted by a gas in an area. So if we were to look at room air, if we had a lot more of a particular gas, then we're going to have a higher partial pressure. And so the idea is if we use 760 as our atmospheric pressure, if we know what percent the gas is, so we know oxygen is 21%, then we just multiply that by 21% and we get about 159, and we're using mmHg. And so what this is we write PO2, and what that means is that's my partial pressure of oxygen. So if we know the atmospheric pressure, which at sea level is 760, now remember that pressure falls with altitude, right? So if we go up in altitude, that's going to decrease. Let's say it drops to 700. Then notice that my PO2 will also decrease. In this case, it would fall to about 147. So when we go up in altitude, since our pressure falls, our atmospheric pressure falls, so does our PO2. So that's why people will say that there's less oxygen. There is, because the pressure has fallen. It's still 21%. So, technically it's the same amount of percentage of gas, but because the pressure is lower, it definitely affects our PO2. And you'll see this is what is going to drive the diffusion in our lungs, right? We need to bring it in. Now we know that CO2 and nitrogen each have different percentages. So the ones we will focus on is O2, and then we will look at CO2. So same idea. If we take 760 and multiply it by 0.04%, which is 0.004, we get 0.3. So look at my PCO2, very, very low in room air, but my PO2 is much higher. Now you're not, again, memorizing all of these, but obviously nitrogen makes up a lot more, so it has a higher partial pressure. And notice in the alveoli, so I told you we still do, that air does go into our alveoli with the nitrogen, but once we get in our alveoli, our pressure, our PO2 falls. It's around 159 what we inhale, and then by the time it gets down in our lungs, it's going to fall. Part of it mixes in those conducting zone, that dead space, so some of it mixes with air, then it mixes with the humidity, and so it falls to around a PO2 of 104 inside the alveoli. Notice the CO2 also changes. It comes in at 0.3, right? But it mixes with air in the dead space, which has more CO2. And so by the time that gets to my lungs, to my alveoli, my PCO2 goes up because there's more CO2 in my airways. I'm trying to get it out. And so that's going to rise to around 40. Now, if we wanted to measure the PO2 and PCO2 in exhaled air, like what's leaving your lungs, you can see that, room air is 21%, but exhaled air is still around 16%, and it also has, some more carbon dioxide. And the reason I mention this is when, you look at mouth-to-mouth respiration, exhaled air, it's still got oxygen in it. So it's still valuable. It still can help deliver some oxygen to the patient. We have a lot of these ambu bags, these basically bags that can either use room air or you can add oxygen to it. But these are a little better because room air has more oxygen in it. So using those with room air is better than exhaled air, but exhaled air is better than nothing. The other gas law is called Henry's law and has two pieces to it, and they're very intuitive. So one is gases move from a high partial pressure to a lower. Well, that makes sense. If I'm giving someone a higher oxygen, 100% oxygen, the higher the partial pressure, the faster oxygen will move. So, if I have a PO2 in my alveoli of 104, well, what if I increase that even higher? So it's just oxygen. So maybe I give them the PO2, I'm making this up now, and it's like 200, right? Because we're going to increase the PO2. That will move faster. That's why we use pure oxygen and why it's a tool. The other idea is that the amount of gas that dissolves, and again, it's dissolving into fluid because it's dissolving into blood, depends on its solubility. So the more soluble, the faster the diffusion. And CO2 is about 20 times more soluble than O2. And so it diffuses much faster in our blood. And we mentioned, right, that we do have a lot of nitrogen in air around us and what we inhale, but it doesn't go in our blood because it's not very soluble. So normally nitrogen is not in the blood. When we have hyperbaric conditions, this is based on Henry's law, this is pressurized gas. So this is the hyperbaric chamber at the University of Maryland. One of my students had her husband and son spend a couple days in here because they had carbon monoxide poisoning. Now, CO, or carbon monoxide, we've mentioned briefly. CO is dangerous, right? It can be fatal because what happens is when hemoglobin gets to your lungs, and we want hemoglobin to grab an oxygen, right? Well, carbon monoxide is 300 times more soluble than oxygen. So when hemoglobin gets up to your lungs, it's going to bind to carbon monoxide. So you're going to become hypoxic, which can be fatal. So these chambers are used if there's carbon monoxide poisoning because you use pressurized gas to force the oxygen onto the hemoglobin. A lot of times they're used for wounds or anaerobic bacteria because those anaerobic bacteria will not like all that oxygen coming in. So they're used to quickly oxygenate blood anytime you're severely hypoxic or to also help with wound care. Now, another application of Henry's law is for scuba diving. So you've probably heard of decompression sickness, aka the bends. So what happens is as you go deeper and deeper, we have nitrogen in our air. Okay, it's in the air, and so it actually now it's pressurized. So once it gets in our lungs, it's able to go into our blood because you're breathing a mixture of air, right? You're trying to simulate air. You're not trying to breathe just 100% oxygen. So the nitrogen, because of the pressure, goes in the lungs. Well, if you come up slowly, these nitrogen, the little black dots here, is going to slowly come out of the lungs at a nice slow level, no problem. However, if you come up too quickly, the nitrogen leaves the lungs and leaves the blood. So let me clarify. As we move up, the nitrogen leaves the blood, goes into the lungs, and you get rid of it. If we come up too quickly, the nitrogen can't slowly leave the blood. Instead, it kind of like comes out quickly. They say it's almost like boiling water. You see these nitrogen bubbles start coming out of your blood. Well, that's a problem. For one thing, they get in your joints, so you have excruciating pain. That's why they call it the bends, because you're bent. It can cause embolism. It can be fatal. So the issue, again, is you need to come up slow to give the time for the nitrogen to leave the blood and be exhaled too quickly is a problem. And this is another example of Henry's law. All right, external respiration. Now we are actually going to look at what's going on here. We have the air in the alveoli and we have the blood in our pulmonary capillary. So what we're looking at are there's three things that affect this. Okay, we want to have rapid diffusion. So number one, we come back to Henry's law, partial pressure gradients and gas solubilities. Number two, we look at anatomy. The respiratory membrane. What is that membrane like that the gases must diffuse across? And number three is physiology. We have to match the blood to the air. You only want to send your blood to the areas of the lung that are ventilating, that have the best airflow. So when we look at our partial pressure gradients, you just saw these numbers. Remember that when we're looking out at atmospheric air, let's say 160, it's close enough. When it comes in the lungs, it changes so that we know our PO2, our partial pressure of oxygen inside the alveoli, is high because we're bringing it all in. Now, when the blood is coming into the lung from the pulmonary capillaries, right? Remember the pulmonary arteries are going to bring blood up to the lung, and they're bringing O2 poor blood in. So this is just showing you the right side of the heart and the left side of the heart. We know that when we look at blood in the pulmonary arteries, that we would say that it is O2 poor and CO2 rich. So this blood is going to the lungs so that it can become oxygenated. And so when it becomes oxygenated, we want it to leave and go back to the heart through our pulmonary veins. This time it'll be O2 rich and CO2 poor because of the gas exchange. So when it comes in with CO2, notice that the CO2 level, and when we're looking at the blood, let me get my color. Let me back up for 1 second and stick to oxygen here. So I'm coming in low O2 around 40. I have a PO2 of 104. So where is it higher? It's higher in the lungs. So what that means is that oxygen will diffuse from an area of high pressure to low pressure until equilibrium is reached. So it's going to enter that blood until the blood leaves at a PO2 of 104. That's diffusion, right? So it comes in at 40, picks up oxygen. Once it's equal, 104, 104, no more movement of that gas, it leaves at a PO2 of 104. Now, if we look at the CO2 moves in the opposite direction. So we said that blood coming from my pulmonary vessels is going to be CO2 rich because it's trying to get to the lungs to get rid of the CO2. So that comes in at a PCO2 of 45. Well, remember the CO2 in my alveoli is 40. So again, we have a difference, right? We have 45 to 40. So gases follow diffusion. They will diffuse, CO2 will diffuse out of the blood into the alveoli because there's a pressure gradient of 5. That will happen until equilibrium is reached. So as it goes through and it gets rid of the CO2, right, it's going to keep happening until it equilibrates with the alveoli. And so it's going to leave at a CO2 of 40 because that's when it's equal. Now, a question I like to ask here is, we're moving the exact same amount of gas, oxygen and CO2. But remember that oxygen needed a steeper gradient. Oxygen needed this gradient of 104 to 40 to force that oxygen in your blood. But CO2 only needs a gradient of 5, right? 40 and 45 to move the exact same amount of air. So why do you think that is? Hopefully you said because it's more soluble. Because CO2 is more soluble, it will move faster. You don't need as steep of a partial gradient. Now, we mentioned the respiratory membrane as well. We looked at this previously. Remember, it has 3 layers. So when you're looking at the membrane, you have your simple squamous epithelial layer of your alveoli, your type 1 cells. You have your simple squamous epithelial layer of your capillary, the endothelium, and then you had the basement membrane between. So we know it's very, very thin. You don't have to memorize it. It's about 1 micrometer thick. But remember, a piece of tissue paper is 20 times thicker. It has a huge surface area. If you were to take your lungs, both lungs, and flatten out all the alveoli, it would fill half a tennis court. That's the surface area inside your lungs. It's huge. There's over 300 million alveoli. So we know we need to have a large surface area and a thin membrane. And that brings us to something called Fick's law. And again, this makes sense. Diffusion is directly proportional to surface area and inversely proportional to thickness. So what does that mean? If your surface area goes down, like maybe you have a tumor in a lung and you have part of your lung removed, or part of your lung isn't working, so you decrease surface area, SA, surface area, right? It's directly proportional. You're going to decrease your diffusion rate. It will take longer for gases to move, but it's inversely proportional to thickness. So if you increase the thickness of the membrane, maybe you have pneumonia and this membrane gets really thick and clogged with mucus. Well, if you increase thickness, then you also decrease diffusion. And so we're pretty much, this doesn't change too much as far as it should be nice and thin in a large surface area. What happens here is respiratory disease, pulmonary diseases typically are going to do what you see here. They're going to have you lose surface area or make the membrane thicker, and that's going to slow down diffusion, which will be a problem because if you don't have enough time to move all those gases, you become hypoxic and you have too much CO2 in your blood. And so the last thing is you got to match the air with the blood. So it's called ventilation perfusion coupling, or they call it VQ. So a lot of times you'll see VQ, V for ventilation, Q for perfusion. So ventilation is how healthy are your lungs? Are your bronchioles open? Are you moving air? Are you fully ventilating? Where perfusion is, how's the blood flow? Are you moving the blood to the area of the lung? And these two have to be in sync. So if you have an area of the lung, let's say we have an area where it's not healthy. Maybe you have bronchitis, or you have a tumor, or there's an area of your lobe that's damaged from smoking. We know that if we can't move the air, then we're going to basically have very low PO2, right? Because we can't get air to that area, and we can't get air out either. So we're going to have low O2. Well, what's going to happen is that your vessels to the area, the blood vessels will constrict. You're not going to send blood to an area of your lungs that isn't working. It doesn't make sense. So anytime we have what's called hypoventilation, or an area that isn't healthy, the PO2 falls, which causes vasoconstriction of the blood vessels, the pulmonary vessels. What you're going to do is you're going to dilate the vessels to the area with the best ventilation, and you're going to constrict the vessels where you have the worst. Well, anytime we have this hypoventilation, we have an issue with CO2, right? We can't get O2 in, we can't get CO2 out. Now for the CO2, we're going to change the bronchioles, because remember, they're the tubes moving the air to and from the alveoli. So if we have poor ventilation and we have CO2 levels too high, the bronchiole is going to open up to try to help you flush that CO2 out. You're going to try to move it. If for some reason we had an area where we had like really low CO2, then we would change the bronchioles and they would constrict. What you're most likely going to see is the situation with poor flow, poor ventilation, and so you're going to want to open up the bronchiole. So when we look at this, we would say that when we have what's called hypoventilation, then in hypoventilation we're having low PO2, right? Then, and what's going to happen is we're going to vasoconstrict our pulmonary vessels, and because we're going to have high CO2, we're going to open up the bronchiole. So you're going to vasoconstrict the pulmonary vessels or arterioles and bronchodilate those bronchioles to try to move the air. And so what you might hear is something called a VQ mismatch. And again, ventilation, the airflow, perfusion, the blood flow. And when we look at things that could cause this mismatch, we can have a lot of factors that can cause issues with the air. Asthma, bronchitis, pneumonia, emphysema, all of these are going to be associated with what we might say hypoventilation. You're not moving the air. And so in all of these situations, we have this mismatch. And so, what's going to happen with the patient with emphysema is the pulmonary vessels will constrict, and they'll try to open up those bronchioles to try to help move the air and get that fix that mismatch. So, there's things they can try to do to restore and obviously treat the condition if possible. Okay, so we talked about what happens, why the gases move, how they move, some gas laws, and we're going to wrap up with how are the gases transported. So we move them in the blood. How do they get from the blood, from your lungs, to your tissue cells? Well, oxygen has two ways that is transported. A little bit of it just dissolves in plasma, 1.5%. You already know most of it binds to that heme on that hemoglobin, and so 98.5% is going to travel that way. Remember that when we were looking at hemoglobin, it actually had 4 heme groups, and each heme has an iron, and I said iron that grabs that oxygen. So when we talk about oxygen being saturated, it means that each hemoglobin has 4 molecules of oxygen. Sometimes we use the words association and dissociation. Association is when oxygen binds, when it binds to hemoglobin, and dissociation is when hemoglobin lets go of oxygen. So we're looking at external respiration right now. So that would be the association, and a lot of times I just call it loading. So we are going to be looking at oxygen loading onto that heme, onto that hemoglobin. And so there's one equation for this that we learn. And what you can see is, remember, this is reduced hemoglobin. So this is hemoglobin that might only have 2 molecules of oxygen. It's never empty, by the way. So when it picks up oxygen in the lungs, so when we have O2 loading for external respiration, notice you have HHB plus O2. Remember your chemistry. The HB grabs the oxygen, and then there's that hydrogen. So that's the equation. When we look at internal respiration, notice it's going to go the opposite direction. So it's one equation. You got to know which way it's going. Is oxygen loading or unloading? And so we have oxyhemoglobin, which is when it's full with 4, and we have deoxyhemoglobin, which is often just called reduced hemoglobin. Either term is fine, probably easier to write reduced hemoglobin, and that's when it's not empty. We'll just say it has around 2. And that's how oxygen moves. It picks it up, it drops it off. Now, CO2 we'll talk a little more about for internal, because remember, it's actually made by your cells. But CO2 has 3 ways. Notice a little more of it just dissolves because it's more soluble, so that's easy. Some hemoglobin binds to let me try this again. Some CO2 binds to hemoglobin. And notice roughly 20 to 25%, and it should look the exact same as what you just saw. Here we had reduced hemoglobin and O2 forms oxyhemoglobin and hydrogen. Well, reduced hemoglobin picks up the CO2 to form carbaminohemoglobin and oxygen. Same thing, right? It goes both ways. So we can have CO2 loading or unloading. So when we're looking at external respiration, we're looking at the exchange in the lungs. So what's happening in the lungs with CO2? Well, remember, we're getting rid of it. We have CO2 unloading from our blood because it's going from the blood into the alveoli, so you can exhale it. So again, it's going to come in attached, and then we're going to have the equation go this way so that the CO2 can be exhaled. So again, just one equation, the arrow tells you what you're forming. And just think about, are you trying to get rid of CO2 and exhale it, or are you trying to attach it and transport it? But the main way that CO2 travels in the body is actually hidden in this bicarb. See that HCO3? That's bicarbonate ion. CO2 is right inside of that. So most of it travels this way. And you've seen this equation before. It was an equation that we did for buffering. Notice again, the arrows go both directions, right? Depending if you're binding it or releasing it. So in the lungs, remember, we're trying, oops, sorry about that. In the lungs, remember, I'll just move it down here. We're trying to get rid of it. So what's going to happen is it comes in as bicarb. That's how it travels. So it's actually bicarb in the plasma. Fixing my pen. So we have the HCO3, right? That's how it's traveling in your blood. And then when it gets up to your lungs, write that neater. It's HCO3, and then it's actually going to go into a red blood cell. So red blood cells have an enzyme. This is an enzyme right here, Ca, carbonic anhydrase, really important enzyme. Remember that enzymes allow chemical reactions to happen faster. So this reaction happens best inside a red blood cell, but because the bicarb's out in the plasma, you got to get it inside the red blood cell. So this will just be a little red blood cell. And this is coming up on the next screen, but I'll just do it here. So what happens is the bicarb comes inside the cell so it can do this reaction. But you can't just throw negative charges inside a cell. You have to replace them. So inside the cell, there's a lot of chloride. They each are -1. So the chloride has to leave. It's called a chloride shift. Bicarb comes in, chloride comes out just to keep the charge the same. But once it gets in, notice it combines with hydrogen. And then you form what's called H2CO3, which is known as carbonic acid. You've seen this equation. I know you had it in 119 for sure. And then carbonic acid is going to break down because of the enzyme, carbonic anhydrase, into CO2 and water. And so the CO2 is going to leave so you can exhale it. So most of it travels this way. And you might be wondering, like, why does it go through all that? Well, the reason is bicarb is one of the best buffers in your body. And so as it travels as bicarb from your big toe to your lungs, it buffers. It's a really important buffer. So it basically does double duty. So let's put this together. You have this picture in your notes. This is what I want for external respiration to put it all together. So if we're looking at this, the setup, right? We're looking at external respiration. We're looking at blood between our gas exchange between the alveoli and the lungs and the blood in the pulmonary capillary. This is just representing plasma. This is my capillary in the box. This is my red blood cell. So we know the blood is coming in, right? That we know it's O2 poor. So if it's O2 poor, it's going to have a PO2 of 40. Now you would know the units are mmHg, but I'm not going to keep writing them right now. We also know that if we have this O2 poor blood, that it's CO2 rich, has a lot of CO2. And so we memorize that it's 45. So we have some oxygen that's just dissolved in it. And we have a little bit of CO2. Again, it's dissolved, so I'm just writing it over here in the plasma because it's dissolved. We know that most of that oxygen, though, right, that when we're trying to like move this oxygen or the CO2, let's do the oxygen first. So we know that when we're looking at our O2 levels, that our levels in our alveoli, let's do purple for that, that it's O2 rich at 104. Now it was 159, but as it goes all the way down through the conducting zone, down to the respiratory zone, we know that the O2 mixes with air, right, and a little bit of water vapor, so it's 104 when it hits the lungs. The CO2 is always leaving. The CO2 and our air in our alveoli will always be lower because remember, we are always exhaling CO2 out, and it will be lower at 40. Now, what's going on here? So we have this O2 poor blood coming in, CO2 rich. We know that there's 3 ways that CO2 is coming in here, right? So we know that some of it is carbaminohemoglobin, and we know that a lot of it's out here in the plasma. And I wrote some here, but we'll just, we have CO2 dissolved. Okay, so I said I would do oxygen first. What's going to happen is we will move oxygen. It will follow its partial pressure gradient so that it will move from the higher PO2 of 104 into the blood, and it'll be on a red blood cell, and it will also be dissolved, right? And so we have this O2 loading. And that means we're loading it. We're talking about the direction into the blood. Now, as it passes by, it comes in at 40. Oxygen enters until the PO2 reaches 104. Now, the PO2, by the way, is representing the amount dissolved. So the amount dissolved in your plasma, right, the higher the gas, the higher the PO2. So a PO2 of 40 dissolved has less oxygen in it than when it leaves at a PO2 of 104. But remember, most of it is going to be attached to hemoglobin. So here's my oxygen loading. It's going to bind to reduced hemoglobin. Notice my arrow. And now I have oxyhemoglobin. And that's how 98.5% of that is transported. Now I kick off a little hydrogen here, right? We got to deal with that in a minute. So when oxygen, right, attaches to hemoglobin, when hemoglobin picks it up, another way we measure our oxygen content is we say that hemoglobin is 98% saturated with oxygen. It's never 100% because of the shape, but it picks it up and it's going to be 98% saturated. And there's one more way we measure the amount of oxygen in our blood. We say for every 100 mLs of blood, there will be 20 mLs of oxygen. So when we're talking about oxygen, we have three ways of discussing it. We can mention the PO2, which reflects the amount dissolved in plasma. We can look specifically at the hemoglobin. How saturated is it? And we can also we can take a blood sample and we can measure the amount of oxygen in it. An FYI, how do they get this 20 per 100? The way they get that is they know that each gram of hemoglobin, and you won't have to do this math, but every gram of hemoglobin actually carries 1.34 mLs of oxygen. So the more hemoglobin you have, the more oxygen you carry. So they do this, the number I'm giving you is based on someone having 15 grams of hemoglobin. 15 times 1.34 is 20. So if your patient has less hemoglobin, then these numbers will fall. And if they have more, they'll go up. So you can see why you might want to know your hemoglobin level. Now, one thing I want you to understand, though, is this process in the lungs, if you're trying to time, how long does a red blood cell have to go by an alveolus? Your blood's flowing. You have a blood pressure, right? It's pushing the blood through and heart rate. So it's moving. It's not like it can just hang out forever for all that oxygen to load. And so what we know is that if you were going to time, let's say you're going from point A to point B. So this is in the lungs, and I want to know how long it takes my little red blood cell to pass through from A to B in the lungs. Well, we know that it has about 3/4 of a second at normal heart rate and normal blood pressure. And if everything's, fine and dandy. So what happens is that it actually, remember the PO2 is 104 and it comes in at 40. It actually oxygenates really fast. And then the rest of the time, it's not doing anything. It's just passing through. So we know that it only takes 0.25 seconds to fully oxygenate your blood, to get it right up there to 104. It's a pretty quick thing. And so then it has an extra half a second so that you have 0.5 seconds here that really nothing's going on. Well, you might wonder again, what's going on? Well, geez, it makes sense, right? Like maybe your heart rate goes up and your blood pressure goes up, like you're exercising, and now it's moving faster. Maybe it doesn't have 0.75 seconds because your heart rate and blood pressure are higher. Maybe it only has half a second. You're good. It only needs 0.25. Or maybe you have a problem with diffusion. Maybe your respiratory membrane is too thick because you have pneumonia or COVID, or maybe you've lost surface area. Well, you have an extra half a second in there to give you more time for that diffusion to occur. So this is really good because, again, with pulmonary diseases, if we didn't have any backup, we'd probably die really fast from pneumonias and all these. So when you have a patient and their PO2 levels low, they've exceeded that extra half a second. Like there's something going on in their lungs. And so again, we say that it leaves 98% saturated, and every 100 mLs of blood, right, is going to have 20 mLs of oxygen. Well, if we look at the CO2 part for a minute, remember that CO2 is going to be moving the opposite direction. So I'm going to get rid of some of this really quick. And we know that CO2 is going to come in and it's going to be unloaded. So we're going to have CO2 unloading because we need to get it into our alveoli so we can exhale it. So CO2, again, some of it had it here, some of it's just dissolved in plasma and it just leaves. Some of it comes in as that carbaminohemoglobin, and then it's released. Now, remember when we did O2 loading, we always form this hydrogen, and we really want to make sure that we don't have too many hydrogens building up because that would be bad. That would change the pH. But what's kind of cool is that hydrogen that got kicked off by forming the oxyhemoglobin is used to kick off the CO2. It's actually used in both of these equations. So we don't have any change in pH with breathing because all the hydrogens formed are actually used to get rid of CO2, which is this really cool thing. It's actually called the Haldane effect. So somebody named Haldane figured this out. And he just basically is showing how these equations drive each other. So when we unload CO2, let's look at this one here. When we unload CO2, see that little reduced hemoglobin? Well, that's just used to pick up oxygen, right? And then when we pick up oxygen, that hydrogen kicks it off. And so we have this nice little feedback loop here where they're driving each other. Now, which came first, I have no idea. And so as we unload CO2, we get reduced hemoglobin to increase O2 loading, and that gets a hydrogen, which increases CO2 unloading. And that hydrogen, again, is used down for the bulk of it. So my bicarb, remembers out in my plasma, that comes into my red blood cell. My chloride leaves, so I have my chloride shift. Now I run this equation in my cell. I get carbonic acid, which is very rapidly broken down into water and CO2. And that's how it leaves. So when my CO2 comes in at 45, remember that the CO2 inside my alveoli is going to be low because I'm always exhaling it. So now I have a diffusion gradient. I have a pressure gradient. We're going from 45 to 40. Same thing. CO2 drops it off, unloads from my plasma until equilibrium is reached. And so when my PCO2, as it goes through, right, by the lungs, it's going to drop from 45 to 40. Now it's equal and it leaves the lungs. And so when I look at my levels for my O2 rich blood in my pulmonary veins going to the left side of the heart, my PO2 is 104 and my PCO2 is going to be lower. Remember, my PCO2 is going to be 40. And we would say that oxygen, right, is in my blood. My hemoglobin is 98% saturated with oxygen, and every 100 mLs of blood would have 20 mLs of O2. And that's how we rest with external respiration. And the next lecture, we'll look at internal.